So next, I'd like to invite Mr. Oliullah Abdal, one of the pioneer young optometrics, I'll say, in India. I have known him since last many years. A wonderful colleague, a wonderful optometrist, and a helpful optometrist all the time that I have been known him for. So, Oli, are you there?
Thank you, Ratuj, for the introduction.
Yes.
I was muted.
Welcome. Yeah, welcome and nice to see you after so many days. So, welcome to Advancing Optometry Education Global Conference organized by Mero Eye Foundation and supported by Tilganga Institute of Ophthalmology, Himalayan Eye Hospital, sponsored by Vaishnav Medicels, and also co-sponsored by Topcon and NIDEC. So we welcome you very wholeheartedly, Mr. Oliullah. So you can share your screen now, and we can continue with your presentation.
Thank you so much, Pratush, for your kind introduction and sincere gratitude to Mero Eye for inviting me for this lecture series, especially this virtual conference, National Conference of Nepal. I would like to share my screen and then go ahead with the presentation, which will be primarily covering on topic on amblyopia management. So, as Pratush mentioned, I am into pediatric optometry and binocular vision since 2013, and I'm one of the student of Dr. Rizwana. So I'm very happy to present in front of her in her presence. So it's great privilege to have Rizwana here as a session panelist over here. So the topic is very common. We'll be talking about amblyopia management, and it is so coming to the topic is primarily amblyopia is the first horizon in terms of management. The common or gold standard still being the patching. Here we'll understand a little different way. So we'll try to understand what are the amblyogenic defects in the visual system, though we know it is something beyond the eye, but what exactly it is and where it is, we'll learn about that. And if you choose a different approach like Dichoptic, what is going to be, or what are the outcomes are going to be there as a binocular approach in the management. This is not the one that I try to explain, but it is just a definition that it is most commonly unilateral phenomenon or sometimes bilateral reduction in best corrected visual acuity, and which do not contribute to any of the structural abnormality of the eye or posterior visual pathway. And so you have anatomically absolutely normal eye, but functionally the visual functions. So not only the acuity, resolution acuity, there are many more things which are affected into it. So this is worldwide prevalence. It varies from 2 to 4% of the population, and it is not very uncommon even in adults. So that is one of the component I want to mention. And nearly all amblyopic visual loss can be preventable. So if you do a timely management, you can actually prevent them nicely. But nowadays, even if it's later stage, it's not too late. But obviously, there will be certain exclusion to it, and we'll discuss those same as well. If you classify them, the commonest one we see is anisometropic, followed by strabismic. Combination of two is not very uncommon as well. Then you have very lesser component of visual deprivation, like you have unilateral cataract, bilateral cataract, ptosis, or some organic factors where you do not see any specific cause, but still the visual acuity is less. I'm going through these slides little first because the core topic we'll be discussing on dichoptic management. To understand neurophysiology, if you look at the visual pathway, so the ocular level, we know it is absolutely normal. So something happens whether in the optic nerve or lateral geniculate body or post that or visual cortex. Let's have a couple of slides for those. So if you look at this slide, which explains that in amblyopia, first, second, and third order neurons, which are predominantly onto the retinal layers, like photoreceptors, bipolar cells, ganglion cells, those are normal. So you don't see any issues lying there. What actually happens is something on the lateral geniculate body, which is fourth order neuron, and then visual cortex, fifth order neurons. For those areas. So if you have early deprivation in life, so what it happens, the shells of the visual cortex and lateral geniculate body, so it becomes pale and shrunken. And then if you just open that stimulation barrier, then there will be no recovery until and unless you do a patching of the good eye. So the moment you close the good eye, then you see the recovery. That's exactly clear the concept of patching therapy, why patching is the most common therapy, because you occlude the dominant eye, the vision starts getting bad. And the best part of it that there was no diffuse atrophy, so there is no permanent loss of the cortical cells, and that's again another region that patient starts improving. But as we know, there is a plasticity period of this monocular neurons, and then until 8 years or 10 years of age, you get this reversing of the component, but later stage becomes very difficult. Now this theory also explains that there are ocular dominancy that happens, so that the one pathway of the good eye or the eye which is having no obstructions takes the territory of the closed eye. So there is indirectly expansion of the visual cortex of the dominant eye and shrinkage of the non-dominant eye or deprived eye. Similarly, if you look at another theory which explains for the Brodmann area 17 and 4C, so this also explains the crowding phenomenon at the ocular dominance columns. So whenever you have unequal stimulus going to the visual cortex, the dominance, there is a significant dominance happen to the eye, and there will be a lot expansion of the non-deprived eye. So it's the quantity as well as the quality of the suppression that happens to the non-dominant eye is relatively explained by this theory. So depth of amblyopia is contributed to this pathway, and that's why if you look at the neurophysiology, so not only the monocular neurons in the early childhood life, so later on, if you have a process to reverse the mechanism, or if you can expand this or decrease the depth of suppression or depth of amblyopia by reducing this dominancy, so probably you may end up in getting very good outcome with any newer approach of amblyopia management. And that's why we all in the pediatric optometry or ophthalmology practices, we keep on searching new and new modalities. So apart from patching, there are medication to stimulate the plasticity or extend the plasticity period, or there are many options which being explored. Out of those, the dichoptics coming to be one of the front runners. And this is exactly why people are looking for those newer modalities. So if you go by the literature, so with the best possible management at this point of time of patching, you land up still getting some amount of residual amblyopia. And these all presentation or this all research talks upon only the resolution acuity. They usually do not talk about the binocular vision aspect altogether. So only in the resolution acuity, you see at least like 2 lines of residual amblyopia at the end of 4 months program. Obviously, when you do it for longer period of time, then the amount of residual amblyopia keeps on going down. But the major barrier to the patching happens to be the compliance, because as the child grows older and older, the compliance rate goes down. And it said to be, if it is more than 5 years of age, the compliance to the patching goes to less than 50% of your prescribed module. So not only the plasticity period, is also the compliance, which is taking a big toll in terms of getting improvement in amblyopia. And there are studies which shows highest reported compliance is only 70%, but the worst side is many more. The time takes to improve from amblyogenic factors to a better acuity, better visual functions. Usually is noted that if you give 6 hours patching per day, you see 4.8 lines, which is highest reported in 4 months. But traditionally, it is a line or 1.5 line improvement that happens on average in 4 months of follow-up time. Then if you look at the adult amblyopia, so there are many studies which says patching is not an option, and that we all know that why it is not an option, because of the plasticity period of monocular neurons, which are over for this patients. And overall, all this concept, apart from this limitation, another problem that happens the moment you stop patching, and then you see at least a line vision drop, which happens in many of the patients. So it's like 1/4, they comes back or drop down by a line or so. If you keep still doing the maintenance patching, like once in a week or twice in a week, but still there will be a drop in visual acuity by more than a line in 8 to 10% of the successfully treated patient. And these are the all reason which led to finding out newer and newer modalities. And the newer modalities also try to look at the factors which associated with the binocular vision. So now this is more common to the pediatric optometrist or the optometry fraternity, that we also look at patients' binocularity, try to look at their hand-to-eye coordination, then ocular motor deficits. So because these are not only the amblyogenic factors that we should look at, these are very important for overall growth of the child. As Dr. Rizwana spoke about, why there are many such factors like saccades, pursuits, or the other component of binocular vision is important for child's overall development. Now, how do we practice this binocular approach or a dichoptic? Dichoptic is nothing but it's just binocular presentation of stimulus, and you have many things to do. You can do a lot in your routine practice. And as simple as that if you have any anaglyphic goggles, like red, green, or red, blue, whichever it is, just to dissociate the eye, use that appropriate filter, and you create an environment where your task is very specific to the eye. For example, on this photograph, if you have a red and green anaglyphic goggles, and suppose you have a playing card like this, where one is covered with a red gelatin paper. So what actually happens, if the patient closes the left eye, the patient do not see this chart, because the red of the right eye is negating this red, and then they do not see anything. So they see a blank card. Whereas the other eye, so the other card, which is covered with the red gelatin paper, because it's appearing in dark, the patient still perceives it. So from the right eye, patient sees the opposite card, whereas from the left eye, patient sees the other eye card. So this is when you have a white background and anaglyphic goggles. When you change the background to black or a reverse polarity, exactly opposite thing happens. So you need to take that consideration very precisely. So if you are giving in a normal room illuminated condition with a white background training, make sure that you are putting something. Suppose you wish to treat eye or right eye for the patient, so make sure that you are putting the gelatin paper onto the card which you are targeted for the left eye or the left side here, so that they start seeing. Now, if the both eyes are open, patient starts seeing both of the cards. Now, patient virtually do not know that which eye is being used, but the brain knows that the brain started using both the stimulus, both the eyes component. So this is one of the easiest environment, and you can recreate this at any task that the child does in their day-to-day activities. For example, if the child needs to do a homework, simple, put the red and green anaglyphic goggles, give a white paper to write something or to draw something with a felt tip pen or a marker pen or a color pencil, which has like 4B or 6B, which has a darker shade. And you can exactly create the environment as I explained to the earlier slide. These are very easy tool. Try yourself at clinic or at home. You will see amazing response and how you can create this environment of Dichoptic approach or binocular presentation of the task. If the patient is reading his book, here I've put a heart chart over there, but even though child is reading a book, and then you can just put the appropriate color, whether it's a red filter or a green filter you put based on your need for the eye that you need to treat for this particular patient. We prefer, or my experience is, if the child is amblyopic from the left eye, try to put the red filter in front of the amblyopic eye. So that's the additional benefit of red stimulus giving or going to the central foveal zone, which will have more of cones responsible for static or your resolution visual acuity. Having said that, so these are the manual tools which are available, which you can create easily in your practice. What else you can do for this patient? Because you can control the contrast here, you can control the target here, but you have something to play with different modules that those are available freely, or even sometime you can subscribe to this kind of activities which are available. Now, again, these are great MFBF tools like Android games. You have stereo blocks, lazy eye blocks, or DioVision. So similar Tetris games where you have the polarities on reverse. So you see the opposite one. So through red filter, you will see the red one, where through blue filter, you will be seeing the blue one. And that is very important. So for example, if I have a filter now, so if I put this, if I cover this, I'll be only seeing the red component over there and the pink one, which is of neutral color for this. And from this eye, I see the boundary and the pink one at bottom. With both eyes open, I am binocular in nature. I have MFBF environment created, and then I need to play this activity. So it's a great tool to give a coordination between two eyes and perform these activities. Now, similar type of activities, there are many available on Tetris based. So like this is one lazy eye snake. You have bubble shooter. So child loves to play this kind of activities. So you can have one of them, or even you can have something like lazy eye breaker. Again, one of the common games that we used to play during our childhood days. Now, obviously, there are many advanced games which are available like this, where there is a lazy eye jump and fly. Now, these are not limited. So you get many of such activities. Results are not bad. So when you incorporate this concept to your clinical practice, you can monitor them, where you can alter the patient's dominancy. I think that's the catch point where you can yield in very good successful outcome from amblyopia management. Now, there are one of the great tool that I love, or I used to practice a lot, is the Binocular filters, where you can control the patient's blurriness or the visual, like balancing the dominancy by degrading the contrast of the dominant eye, which will have a Binocular scale like this, where you can degrade the quality of vision. So you have like 0.1, 0.2 logMAR, 0.3 likewise. So the one filter, suppose you put 0.5 in front of a good eye, so the visual acuity usually tends to go down by 5 logMAR lines. And it largely helps for routing spectacle where you just put the press on Binocular filters on top of the dominant eye. This is also a very good tool. So you combine this technique with your Tetris games, that can yield you excellent outcome in your clinical practice. Now, as we move forward, as we become more and more possessive about better and better activities,
the CureSight system trains the brain to work with both eyes simultaneously, while the patient watches their favorite videos at home, wearing customized 3D glasses. CureSight is a fun and engaging activity that dramatically increases both compliance and the treatment's effectiveness. To treat the root cause of amblyopia, CureSight uses eye-tracking technology to blur the center of vision in the image shown to the dominant eye according to its gaze position, while keeping the rest of the image sharp. At the same time, the amblyopic eye sees a clear vision of the viewed content. This encourages the brain to complete the blurred information from the amblyoptic eye, improving its visual acuity and developing stereo acuity as the eyes learn to work together.
That you are talking about, but what it did, it incorporated some technology to track the eye of the child that using or the dominant eye and the non-dominant eye. And if you summarize the concept, that it is almost an alternate to patching, is a modified method, because the game also there are dichoptic presentation, as in both the eyes are open and child is seeing. What it does, it blurs the image, what we did in the Binocular filters. So it also has a graded tool or filter where it blurs the image from the dominant eye and forces the amblyopic eye to see better and better. So as it is combination of a dichoptic approach and this Binocular filter concept, so it is a partial binocular approach. It's not completely binocular because it is still, the patching component is there. It can yield to very good improvement and visual acuity, but we are not sure what happens to that improvement in that stereopsis. So there are data available from the manufacturer, which actually they presented very limited number of patients. And as you see that baseline visual acuity was around 6/15 to start with. And by end of 8 weeks, they improved to 6/9. And then after that, stagnant. So it's almost similar to the patching. Patching also, as you saw in my previous PEDIC studies, which says at the end of 4 months of treatment or patching therapy, still you have 85% patient to have at least 2 lines of visual acuity deficit. So exactly 2 lines of visual acuity deficits in terms of you have 6/7.5 and 6/6 in logMAR to have deficit. Now, interestingly, this data which is being presented, it is all patients who already had a baseline stereopsis. So all of them were having very good amount of stereopsis to start with. So why this is important? So there was no suppression as such. Now, in our practices in India, we see a lot of patient comes with the complete suppression. The density of suppression is so high that if you approach with this method, then probably you will not get any kind of improvement, because to break the suppression, you need something to give a better treatment modality. But what makes it revolutionary change is the compliance rate. See, at the 95% child, they adhere to the protocol, and that's the key of success. So even in patching, you need to increase the compliance, your success rate automatically goes up. So only 20 patient data they have presented, and it improved by, as I told you, from 6/15 to 6/9, with stereopsis from a baseline to 204 seconds of arc to 68 seconds of arc, but it do not show any data on patients who already had suppression. Now, to move forward, we have
the good news is that lazy eye disorder can be treated quite successfully with vision therapy. However, current methods of home vision therapy are repetitive and boring, and it's no wonder kids don't enjoy doing it. Here is where Amblyoplay comes in.
Oli, I think the video
Amblyoplay is the latest vision therapy solution for kids, which can be performed in the comfort of your home to play games on a tablet
so video,
or computer.
let me translate that.
Our advanced
So what
self-learning
it's saying,
algorithm
program,
provides
now
every
those
child with a
Tetris games
personalized
you
training
saw
program.
in the
It combines
Play
games
Store
and exercises that
Oli, I think
stimulate
you
the
can
lazy
probably
eye
mute
while
the
teaching the
video,
brain
mute
how
the
to
audio
use
of the
both
video,
eyes
only
at the
play the
same
video.
time. In just 30 minutes a day with Amblyoplay, your child
I'm
can
not sure,
train
you're
and
not
improve
hearing
the
my
lazy eye's
video
vision
sound?
without even noticing. The training can be done monocularly with an eye patch or binocularly with Amblyoplay glasses. These special
we
binoculars
can hear
split the
both
image for
you
each
and
eye
video
so that
as
the
well
child receives stimuli
at the
more
same
precisely
time.
and actively uses both eyes at once.
Okay, not sure whether you heard the video voice or not. So what this program, what they did is they incorporated those Android games or Apple games which are available. They made it more customized. They made a device kind of thing, especially for this amblyopic child, and then they are giving to the patient. So it's attractive or a packaging system where they made all these programs which are available in a single platform to help the child. Again, if you look at the concept wise, it's a combination of monocular and binocular activities. So similarly to the earlier one, it also does a virtual patching of the good eye with a dissociative target, because it only asks you to play with the amblyopic eye, and the dominant eyes get patched virtually. And then partially there are few activities which are with the binocular approach. And then again, when it is not a true dichoptic or a binocular approach, you may not land up in getting stereopsis for this kind of patient. And again, they do not have any data at this point of time to share.
To properly target different.
Let's move on to the next activity, which is on DigRush.
Other gameplay information on the other eye. So as a patient, as a user, the only way to properly play the game is to use both eyes, and this is exactly what we want as a treatment, because by playing, you're training your brain to make a better balance of the usage of your eyes, recovering the.
On this particular activity, they made their own games and has a lot of interaction based on dichoptic principles. As you saw, those activities, which are great tool again to give you good results. So there are some publications with it, and then if you see the summary, it is again combination of monocular and binocular activities. It also does a virtual patching of the good eye, partial binocular approach. Then stereopsis, again, we do not have data from a suppression state to a state where the patient will have a binocularity at the end of the program. Similarly, we also went up and got this program developed for trying to bridge the gap between all the activities which are available. So this is the program that we are working on.
Dichoptic therapy, a contrast-adjusted stimulus, is presented to each eye, with the better eye getting the stimulus with reduced contrast. It promotes development of binocular vision by reducing inhibitory interactions and suppression within the ocular dominance column. Bynocs now offers this dichoptic anti-suppression therapy in the form of games. The better eye receives weak, noisy signals as compared to the amblyopic eye. With progressive improvement in visual acuity, the games can be made more difficult with control on the size, speed, and crowding of the stimuli. There are different games with a scoring system for better patient engagement and compliance.
So the approach that we adopted is almost similar, but what improvisation we did is making it purely a concept of starting from anti-suppression first, so that even though in presence of denser suppression, you can come out or take that amyloidogenic factors first and then introduce activities to improve their resolution acuity. And we do see a very significant improvement in both resolution as well as their binocular visual functions. So we have data, pre-publication data, couple of them. So will come up very soon. I'm not giving in detail of them, but overall 150 subjects we're coming up with for presentation, where we'll have age group of like 6 to 10 years as an interquartile, median age of 7, where anisometropic amblyopes were the highest. If you see the combination of right and left eye, where isometropic or bilateral amblyopes are 31. And these are the kind of improvement you see in only end of like 20 sessions of them, which is 4-week span. And you see almost 4 lines improvement in this right eye, similar improvement in the left eye as well. And then in the isometropic group, also similar kind of improvement. So there is no special or different outcome for the different eye group. The best part of it were the patient who did not had any kind of stereopsis to start with, or all suppression based patient. So if you see the kind of stereopsis that improved with a random stereogram after the end of program. So those who did not had stereopsis in the right, like anisometropic right eye, so 90% of them actually gained them. In the left eye, 80%, and in case of bilateral, all of them actually gained their stereopsis from absent level. And these are from baseline. If somebody already had stereopsis, the kind of improvement that they had during the course of treatment. So these are just general overview at all three together. So I'll be not going in detail of it, but summary of thing. If you see the working principle, it is all try to be in terms of the MFBF concept, but somebody is trying to work on just presenting binocularly and trying to do a mix of matching and a binocular approach, which is a completely opposite mechanism that it works, where we feel that it needs to be only one way, whether you choose monocular or a binocular approach. And with this, I would like to stop the presentation, and then if you have queries, we can go ahead and discuss. Thank you so much once again.
Thank you so much, sir.
Thank you. Oh, yes, Kapil.
All right. Sir, please, can you continue? Okay.
Yes.
Yes. Thank you so much, Mr. Oliullah Abdal, for wonderful presentation on amblyopia. I think amblyopia always has been a mystery for a lot of optometrists, and continuous research is going on about the amblyopia and how it progresses or how it can be improved from last many decades. So thank you so much for the wonderful presentation.